Hello, and welcome to this RPTH research recap, where we dive a little deeper into the science being published at RPTH. My name's Bethany Samuelson Bano. I'm an associate editor at RPTH, and I am a hematologist who specializes in the care of adults with the potential to menstruate or become pregnant in Portland, Oregon, in the US. And I am delighted to be here today. It's my pleasure to introduce Doctors Ava Hamulyak and Luke Sherriz. Dr. Hamulyak is an internist hematologist in training at the Amsterdam University Medical Centers. Her research focuses on thrombophilia and complications of antithrombotic treatment. Dr. Sherriz is a vascular medicine fellow at Radboud University Medical Center and a postdoctoral researcher at the Leiden University Medical Center in the Netherlands. He has a special interest in sex-specific aspects of thrombotic diseases and the role of thrombosis and thrombophilia in pregnancy complications. They recently published a paper in RPTH entitled Heavy Menstrual Bleeding on Direct Factor 10A Inhibitors, the MEDEA Randomized Clinical Trial. This paper is very exciting because it is the first randomized trial to look at treatment options for heavy menstrual bleeding in patients on 10A inhibitors. It's a common problem, and it wasn't really well captured or understood in the early days of DOAC therapy. So I'm very much looking forward to hearing this presentation. For those of you joining live, please leave your comments, which we'll answer during the discussion. Dr. Hamulyak and Dr. Sherriz, we look forward to hearing your presentation.
So thank you so much for the kind introduction. We are really excited to be here and given the opportunity to talk about this study. And of course, we're presenting on behalf of the entire MEDEA team. We're very grateful to all the MEDEA investigators and also, of course, to the study participants. Important to note, the MEDEA study was supported by an investigator-initiated study grant from Boehringer Ingelheim. And Boehringer Ingelheim markets dabigatran, which is one of the anticoagulants under investigation in the MEDEA study. And to set the stage, heavy menstrual bleeding is reported to occur in up to 70% of women using direct oral anticoagulants, the first choice for most anticoagulant indications. And most data we have involve studies on persons using 10A inhibitors. And if you look at the randomized controlled trials comparing the DOACs with the vitamin K antagonists for the management of venous thromboembolism, heavy menstrual bleeding was more common with the 10A inhibitors than with the vitamin K antagonists. But intriguingly, heavy menstrual bleeding was less common with dabigatran compared with vitamin K antagonists. And it should be noted that, unfortunately, heavy menstrual bleeding was not a pre-specified outcome in these studies. These were all post hoc analyses, and there's no direct comparisons between dabigatran and 10A inhibitors available. And there is now also a robust amount of evidence showing that heavy menstrual bleeding associated with anticoagulant use significantly impacts quality of life, is associated with a risk of hospitalization and a risk for the need of medical interventions. So it's a common problem which substantially impacts quality of life. What are the current proposed strategies for the anticoagulant specialist? Of course, next to considering involving the colleagues from gynecology, and the proposed strategies are to add tranexamic acid during the days of menstrual bleeding, to switch anticoagulants, for example, to switch to dabigatran or a different type of anticoagulant, or to consider to reduce the dose of anticoagulant during the days of menstrual bleeding. And this is suggested only after the primary treatment has been concluded. And for these last three proposed treatment strategies, unfortunately, there is an evidence gap. There's no evidence guiding our decision making, and we do not know how well these strategies work and which one we should prefer. And this is the reason we set out to perform the MEDEA Randomized Clinical Trial, which was an open-label, pragmatic clinical trial. and for which the key inclusion criteria were that we included premenopausal women who used 10A inhibitors, so apixaban, edoxaban, or rivaroxaban, with an intended use for over another 3 months for any indication. And one of the inclusion criteria was that there is established heavy menstrual bleeding. And this was based on a pictorial bleeding assessment score, the PBAC, which is a common measurement used in the field of heavy menstrual bleeding, which should be over 150 for participation. And in the design of this study, as shown in the figure on the left, women were identified in clinical practice, and potential participants who were interested in study participation were asked to complete a PBAC score at their next menstrual bleeding episode. And if the PBAC score was over 150, they were randomized to either a switch to dabigatran, to continue the 10A inhibitor with tranexamic acid on the days of menstrual bleeding, up to 4 days, or to continue the 10A inhibitor without any changes. And the primary outcome was a change in the PBAC score over the different time points in the study. And the advantage here was that we could compare the different time points after randomization with the time point before randomization, so that each participant could be compared with themselves in a way. And the estimated sample size was 120 participants, 40 participants per study arm. And this was based on a assumed clinically relevant difference in a PBAC score of 25%. So, and for the next part, I'm more than happy to hand over for the discussion of the results.
Yeah. So we had 16 academic and non-academic hospitals in the Netherlands participating in this study, as you can see above. We started screening and including women in April 2020, and screened a total of 24 women for study participation, of whom eventually 16 were randomized into one of 3 study arms. Unfortunately, the trial was stopped in November 2022 before meeting the intended sample size because of the low inclusion rate. We do present the results. If you continue to the next, here you can see an overview of the clinical characteristics of the women participating in this study. The main indication for 10A inhibitor therapy was venous thromboembolism, also as we expected. And as you can see, that the majority of women had been on long-term anticoagulation prior to study participation. All the way at the bottom of the table, you can see the PBAC scores at baseline, which were quite high and well above the 150 cutoff that we had set as one of the inclusion criteria. This figure shows the mean differences in PBAC scores before and after randomization for each of the treatment groups. The numbers are small, not many women were included, but as you can see, in red and in yellow, the women who were switched to dabigatran, or the women who continued 10A inhibitor therapy but had tranexamic acid added during the menstrual period, had quite a reduction in the PBAC score, approximately 200. The figure also illustrates that there was quite a big difference between the individuals, especially in the no intervention group at the bottom. Important to note is that we did not record any adverse events during the study period. So unfortunately, the study was terminated early after the inclusion of only 16 women. The recruitment rate was low, and we did not expect to reach the intended sample size of 120 women within a reasonable time frame. Several factors have contributed to this. The COVID-19 pandemic certainly did not help, but we also found the number of eligible participants lower than expected. Heavy menstrual bleeding occurs quite frequently, but we speculate that it may not always be explicitly discussed as a potential side effect of anticoagulation in women who are counseled or during follow-up. So there's definitely room to increase awareness, both among patients, but also among treating physicians who start these women on anticoagulant therapy. There's also the fact that most premenopausal women with venous thromboembolism typically require short-term anticoagulation due to its association mostly with hormonal factors, short-term meaning 3 months. And we specifically said that the women we want in this study are the women who have an indication for anticoagulant treatment for more than 3 months. Also, we noticed that a PBEC score below 150 was the most common reason for exclusion in the study. The PBEC is quite user-friendly clinical tool. It's often used, and the cutoff of 150 is in line with the current international guidelines. But we considered that maybe also alternative instruments to quantify heavy menstrual bleeding, to objectify it, but also instruments that capture adequately the patient's experience could be considered as a primary outcome measure. And I think those are the most factors that need to be discussed in interpreting the data that we are presenting here. So solid conclusions cannot be drawn given the small sample size of the study, but our findings are hypothesis generating and suggest that both a switch to the bigatran and adding tranexamic acid may reduce bleeding in these women, and may therefore be adequate management strategies. I think we don't need to underline even more the need for evidence-based treatment strategies for anticoagulation-associated heavy menstrual bleeding. It's evident. And increasing awareness among healthcare providers, whether it's the hematologist, whether it's the vascular medicine, the gynecologist, everyone involved, that will be absolutely crucial for better counseling these women and also for better supporting these women. Lastly, we would like to thank all the women who were willing to participate in this study. Last but not least, we couldn't have conducted this study without all of our collaborators, and especially Dr. Hanke Wiegers and Professor Saskia Middeldorp, who have helped us out a great deal. And we feel very excited that we are presenting our results today also on their behalf.
Thank you so much for that excellent presentation. I know I have a few questions. There's also a couple of questions in the chat. Just like to remind folks who are listening live that you're welcome to type your questions in. The first one I think that you sort of already addressed about the main reason of women not participating. And it sounds like there were a few, but really we're not capturing this in our everyday clinical practice is kind of what I heard from you guys.
Yeah.
And then the next question was, do you think the low recruitment rate affected the power of the study?
Yes, for sure.
Yeah.
Yeah.
As you discussed, there's only so much you can do about that, unfortunately. I think it's still remarkable that your findings were as impressive as they were, despite the very low power. I think that's very intriguing. We have one more question from the chat. What is the trigger criteria for patient education, which a patient should report concern of heavy menstrual bleeding to their anticoagulant manager? So I think the question is, for patients, what should they be looking out for that they should bring to their provider if their provider isn't already asking about it?
So I think if I could take this question, I think it's important for everyone prescribing anticoagulants to inform patients that it is likely their bleeding episodes increase in terms of duration or bleeding volume. And I think if there's especially if there's interference with daily life, but also even preferably even before that, they should definitely contact us as a healthcare provider. And also mention that it is, I always in clinical practice mention, it is common, it is likely bleeding will increase. And also mention that there are strategies or options to consider and discuss then.
Great. Yeah, and also we are seeing some use of the 7-2-1 rule as a very patient-friendly approach. So periods lasting longer than 7 days, which I think we know a lot of these folks, they have periods lasting 8 days or longer. Changing a product more often than every 2 hours. That's really specific to pads and tampons. And then passing clots larger than a quarter or a euro or whatever the local currency is, are things that I've tried to give patients. We have a
Thank
lot of
you.
questions.
Really helpful.
Yeah,
Yeah,
very.
it's hard to educate patients about, we kind of have our gestalt, we ask these questions all the time, and then what you actually tell patients that's easy for them to stick and take home. All right. Somebody's asking about any recommended patient education materials that you would recommend. Well, it's a little bit difficult because it's going to be language specific depending on your nation, but do you guys have any you routinely use?
No, I am aware that some of my colleagues from the gynecology department, but that's for heavy menstrual bleeding in general, not just anticoagulant associated heavy menstrual bleeding. They have materials that they use, but for us, it's not common to use in clinical practice.
Yeah, I not aware of
Unfortunately,
any.
though.
Yeah.
This is we have some work to do then.
Exactly.
I think so. I think it's an amazing suggestion, and it's definitely something we
Yeah.
need. If someone who is listening has a good suggestion, please share it in the comments. And otherwise, we will have some work to do, because I think it's a very important suggestion, definitely.
Yeah. And I love the idea of working with our gynecology colleagues. I think that's super important. We have a lot to share and educate each other on.
Yeah.
Dr. Macris says, congratulations on trying to do the RCT. Have you looked at the prevalence of HMB on DOACs in your clinic patients?
So the question is about the prevalence in the clinic, or how many patients were eligible for the study of the patients we screened. Is that would that be the question? I think so.
I think
right?
his question is more how often you're seeing it in your clinic.
Quite often, I would say.
Yeah.
That would be the short answer. Yes.
Yeah. So also for me, I don't have any exact numbers, but indeed we see it quite often, and not just in the clinic, but also these women coming into the ER with deep anemia. So I think both there and in the outpatient clinic that we notice it quite often.
Yeah. And as you both pointed out, it's very hard because these weren't predetermined outcomes in the studies. And as much as we love our ISTH SSC criteria for major bleeding and clinically relevant non-major bleeding, those are really intended for one-time events. And I think what we don't realize is, A, people expect to have some menstrual bleeding, so they're probably not going to be as quick to call attention to it as if they're suddenly having GI bleeding. And B, this is a reoccurring thing over time. And certainly people can be losing blood faster than they can make it up between periods. And so I'm going to insert my own question here because I can. What would you do in future studies of DOACs or other anticoagulants? How would you set up a study to appropriately capture the rates of heavy menstrual bleeding and make sure that that's not falling between the cracks?
I think that's a very interesting question. It's obviously also something that we discuss. I think if you really want to address how big the problem is, because we are noticing women are reporting it, then there's two things to do. The first thing is, how do we adequately quantify heavy menstrual bleeding? There is several tools that you can use, and the PBAC that we used in this study is one of them. But the other thing is that also the patient experience is very relevant in this. So we speculated, and I think we also wrote that down in the original paper, that okay, maybe the criterion of 150 was not met, but these women notice an absolute increase in their periods after starting 10A inhibitor therapy. So ideally a tool that is incorporated in the studies to address it, but these are under development. We are aware of that, but not being used as of yet. So.
And I think, didn't you all also look at a quality of life metric that I don't think the results made it into the paper, but I believe you included that as well, correct?
Yeah, we did. We did.
Excellent. I think another challenge that we face realistically is when we do these studies, like the average age is usually about 70, right? And it's usually 50+% male. So we're way under enriched for menstruating individuals in these studies. And yet, obviously, as soon as these drugs are on market, we're prescribing them to folks who fall into these categories. So I think that's another big challenge. And I think something that we need to be keeping in mind when we're doing future studies is to make sure that we're including people at risk for this outcome.
Exactly.
Yeah.
Definitely.
All right, we have another question. I think they kind of answered their own question, but they asked what was the reason for the extended anticoagulation, and they were asking if it was mostly unprovoked VTE events, why they needed anticoagulation longer than 3 months.
Yeah, so unprovoked VTE events or recurrent VTE.
Okay, great. We have another question about why do you think there was a decrease in the PBAC over time? I think they're referring here to the control group. They're obviously not to the same degree that you saw in the dabigatran and TXA groups, but they were asking about sort of what's the natural history of this if we don't do anything, I think is the spirit of the question.
So I think if you there are two things I think to consider. So if you look at outside of this study, if you look at the cohort studies, for example, the study by De Young in blood several years ago, you see that the first bleeding episode seems to be worse than subsequent bleeding episodes. And this could be due to many reasons. For example, the high dose during the initial treatment phase of VTE, and then maybe interventions take place after which bleeding decreases. In our study, actually, and of course we can't draw any strong conclusions because the groups were really small, but on average, in the control group, the PBAC, if I'm correct, on average, it did not really change, right? No. Of course, you see some spread there. And of course, we don't know. It could be some natural history, some regression to the mean, but on average, it didn't change. But once again, really small groups. I can't emphasize this enough.
Yeah.
Excellent. We have somebody else bringing up the issue of dabigatran and how there is no evidence about switching to prophylactic dose. For example, rivaroxaban, we can switch to 10 milligrams, and wondering, how does that play into your decision? And I would love to know what you guys are doing in your own clinical practice when you see folks with HMV now. Are you switching to dabigatran? Are you adding TXA? Do you do both? How are you approaching it?
Yeah. Well, for me, it's both. So I have patients indeed in whom I added tranexamic acid who are very happy with it and did not have the issue anymore. But I have also had women switching to the dabigatran who were absolutely satisfied with that and very happy that there was this option without even having to take any more pills. And I think for you, Luke, it's the same, right?
Yes, and I, to be honest, I do not personally discuss often so I do not extrapolate the reduced dose strategy to the dabigatran, to be honest. I don't know how other colleagues approach this, but for the reduced dose strategy, of course, the dose is less, so often it also improves menstrual bleeding outcomes. But I do not translate the reduced dose strategy to dabigatran to answer the question. But of course, I would be very curious to learn how other colleagues approach this.
I have to be honest, in the US, it's sometimes hard to get. Dabigatran isn't like first on formulary for our insurance companies. And so I think I lean towards adding tranexamic acid just because it's often the route of least resistance, and have had some good success with that. I wonder for both of you, keeping in mind that sometimes fibrinolysis is actually important to breaking down these clots that people have, and that TXA is an antifibrinolytic. We know without question at this point that TXA does not cause clots. I think that question has been beaten to death. However, Do you wait a period of time before you initiate TXA in patients with a recent VTE, or do you, are you more likely to do it in a patient with a smaller clot? Kind of, what are your thoughts around that?
So maybe I can have a go. So often when patients present, of course, with anticoagulant associated heavy menstrual bleeding, it's often after 4 to 5 weeks after the first menstrual bleeding episode occurred. So often of course, the evidence is not there, just like you said, we don't know, but I'm comfortable with after 4, 5, 6 weeks after the initial treatment phase to add it. And I also discussed this with the patients. But of course, with heavy menstrual bleeding related to anticoagulants, often you do not have to luckily start it early on.
Yeah, no, I agree with it. I have the same approach indeed in clinical practice, because it's usually not needed in the let's say in the first 1 to 3rd week after the initial event. And so I feel comfortable after that starting it.
Great. And so that brings up in my mind the question of, at least in the US, what we often see happening, these women come in, as you have pointed out, with estrogen-associated VTE. It's often in the setting of combined hormonal contraceptives. They come into our EDs, they get the rivaroxaban started, and they remove the birth control pill at the same time. And that's when we do have pretty immediate, pretty heavy bleeding. What are your approaches to that? What are your thoughts about that? Do you think women really need to come off of these combined hormonal contraceptives when we're treating them? Ava, I'll send that to you first, and then maybe Luke can share his thoughts.
Yeah, so no, that's a very common question. It's also usually one of the first things that we get asked. Is this the cause of of the clot that I got, and do I now have to stop it? No, in practice, I actually say continue while you are on anticoagulant therapy, especially for this reason, because we know if you then stop it immediately, the bleeding will be even heavier. And that's absolutely not what we want. So we continue it at least for the duration of the antithrombotic therapy.
Yeah, and I think it's important to add that for this strategy, there's actually, I would say, fair evidence to support the safety, that it's safe in most cases, in the vast majority of cases, it is safe to continue hormonal contraceptives simultaneously with therapeutically dosed anticoagulant therapy.
Totally agree. If somebody ever gave me 3 wishes, one of them would be that my ED colleagues were aware of this data and didn't stop the birth control pills.
But I echo what Eva is saying, that we are asked the question more often and more often. Yeah. So awareness is really getting better, at least in our practice. Yeah.
That's great. Yeah. I will just mention this briefly. Somebody very kindly put in the comments a reference to a JTH article that I'm actually the first author on, so I'm not going to belabor that too much. But we do have a little commentary on the fact that virtually no patients in the factor 11 inhibitor trials were at risk of heavy periods, and it continues to be a problem in our study design. We have some congratulations on your great piece of work. And there was a question about whether you considered or excluded other possible causes of heavy menstrual bleeding in these patients. They're saying, especially gynecology, I think maybe a reference like fibroids or structural causes.
Yeah.
Luke,
yeah,
go ahead, Ava. Sorry.
I think Ava can answer this question. Is the best to ask.
Yeah, no, so we did consider that indeed, but as each woman participating in the study served as her own control, we compared each woman to each woman before and after. So if they already had it before and after, the reduction in the PBAC, let's say to evaluate the effect of the intervention that we did, would not have been affected by the underlying thing. But obviously it was a close collaboration also with our colleagues from the gynecology department. And indeed, sometimes, I think Luke also pointed it out in the beginning, that there are other options, but it's a multidisciplinary effort in trying to get the best strategy for each woman. But we did take it into consideration.
Wonderful. Another question, if you're designing another trial, what score will you choose to monitor menstrual bleeding? Luke, you want to take first crack?
So this is something we are heavily debating within our group, and we are currently collaborating with several expert gynecologists on how to approach this. And what we actually would like to do, but which our future plans is to discuss with patient representatives, have a study project to actually ask them which of the different measures defined by different expert reflects your experience the best, which is the best one, and which should be the primary outcome. So this is something we hope to do in the future, and something that has come up is that the answer might be the question of did your bleeding episode change, and is it impacting your daily life, yes or no? So this might be very well be the outcome of that study, but of course still we have to do it. But we're very keen on performing the study to actually answer this question.
Yeah, and I think the key element in any such a study would be involving the patient perspective, a patient representative, someone who has the experience, someone who knows what is relevant, because I think in that you improve not only the study design in itself, but especially also the outcomes, how to put this into practice, the results of your study. I think that's key.
Yeah, absolutely. And the current FIGO definition of heavy menstrual bleeding is excessive bleeding that interferes with a person's physical, social, emotional, or material quality of life, which is what we should be using clinically. I think a little bit more difficult to compare before and afters with. So I love the idea of getting patient representatives involved. The MBQ is, which I think is what you guys also use, is a quality of life metric. It doesn't have a cutoff for heavy menstrual bleeding, but perhaps that's less important than figuring out the quality of life.
Exactly. Yeah.
We are running out of time here, so I'm going to combine two questions into one, and then we'll need to wrap up, I think. So there are a couple of questions in the chat about how you approach continuing combined hormonal contraceptives in patients on anticoagulation. Firstly, do you feel comfortable continuing them when patients drop to prophylactic dose? And secondly, how long before stopping anticoagulation do you want to see those combined hormonal contraceptives discontinued? Ava, do you want to take first crack at that?
So I think it's a difficult question to answer, also because the patient is central also in this decision making. So if I counsel patient on contraceptive methods, whether it's combined oral contraceptives or whether it's intrauterine devices or whatever, I counsel them on the thrombotic risk, and it's really shared decision making. So it's also really an individual choice for each patient, because there are women who say, well, I don't want any intrauterine device, even though it's associated with a low thrombotic risk. I do want to continue with this or that. How do we do? So I don't have a standard format how to approach that, but it's really shared decision making. And I think, Luke, you have the same approach, I guess.
Yeah, sure. And of course, the answer, if there's evidence to support the safety of continued hormone use during, I think prophylactic dose means reduced dose strategy. We don't know. We really don't know. So it's shared decision making with the patient, I think, and I can't give a strong answer here. And there was another question about how long before the anticoagulant cessation should we stop oral contraceptives. So also there we do not know. There is a pretty neat study from the group of Mark Blunden, which looked at coagulant changes after stopping hormonal contraceptives, and that takes about 4 weeks. So that's something to consider there. I don't know if you do the same, Bethany and Ava.
I usually try to stop or transition to something else about 4 weeks before, specifically if we're talking about somebody who had their first clot in the setting of a combined hormonal contraceptive. I think, something else that we all need to make sure we're keeping in mind is the risk of pregnancy, right? The risk of VTE recurrence on pregnancy is so much higher than with hormonal therapies. And I think as hematologists, as internists, I think we're prone to forget that a little bit more than perhaps we ought. And so I think we need to be taking that into consideration with our risk benefit analysis. Thank you so much, Dr. Amoliak and Dr. Sheres, for your work. This has been a really enjoyable chat for me. We talked a lot about the importance of recognizing heavy menstrual bleeding, the importance of quality of life and the patient perspective, and the importance of modifying our future trials so we make sure that we're capturing these events. So we hope that viewers will all read the full detail of your paper on our site, rpthjournal.org. And with that, thank you so much for your time, and everybody have a great rest of your day.
Thank you. Thank you.
Thank you.
Thank you.